Hello, everyone. Welcome to Asia Novel Seminar, organized by Arthroplasty Society in Asia. This program is designed to establish a professional arthroplasty forum that arthroplasty surgeons from all over the world can be connected to share their personal ideas, clinical experience, and cutting-edge techniques. I'm Dr. Liu Xianzhe from Joint Surgery Union Hospital, Tongji Medical College. I'm privileged to moderate today's section. This is the third episode of ANS Season 3. In this episode, we will focus on the prevention, diagnosis, and treatment of surgical site infection after TJA. Today is our honor to have special guest here, Dr. Antonia Chen. Please allow me to give an introduction for her. Dr. Antonia Chen is the Director of Research for the Division of Adult Reconstruction and Total Joint Arthroplasty in the Department of Orthopedic Surgery at Brigham Women's Hospital, who specialized in primary hip and knee replacement and revision. She recently served as the president of the MSAS and is a appropriate user criteria leader for the AOS Evidence-Based Quality and Value Committee. In the AAHKS organization, she is vice chairman of the Women in Arthroplasty Committee and is a member of the International Committee. Dr. Antonia Chen has also been recognized for her scientific analysis as an associate editor for the COR journal and associate editor for the AOJ journal. Additionally, she sits on multiple editorial boards for orthopedic journals, including JBJI, KSSTA, Ball and Joint, and Healthcare Transformation. Internationally, she is a board member of the European Knee Association, EKA, and leads the research committee. Let's give a warm welcome to Dr. Antonia Chen.
Thank you so much. It's such a pleasure to be here. I'm so honored to be here and talking about an important topic that affects both you in China, both us in the United States, and throughout the entire world. So thank you very much. It's exciting.
Thank you, Dr. Antonia Chen. Now I will give introduction for our episode. The surgical site infection are common healthcare-associated infections. The number of SSI is probably underestimated, as almost half appear after patients discharged from the hospital. SSI after orthopedic surgery can appear up to 1 year postoperatively with relatively low frequency during hospitalization. Periprosthetic joint infection, PJI, may appear even later at between 3 to 24 months postoperatively. Patients with SSI stay in hospital longer and have higher mortality, more readmissions, and increased healthcare costs. SSI after orthopedic surgery is associated with functional loss, amputation, high implant failure rates, poor outcome, and reoperations. However, it has been reported that the factors affecting wound healing may have more to do with aseptic and surgical technique rather than the other factors, which means that SSI are largely preventable. Almost half of them are estimated to be preventable with evidence-based strategy. Today, Dr. Chen and I will present two topics on prevention and status, diagnosis and treatment of SSI after TJA. And then there will be a case discussion for SSI. It's also welcome to have your questions that we can discuss later after seminar. Now, let's welcome Dr. Chen to give us the speech.
So my talk is specifically on the status and prevention of surgical site infections in total joint arthroplasty. These are my disclosures, none of which are directly relevant to this talk here. So what are we preventing? I hope you didn't eat anything yet, because what we're trying to prevent is infection. And we unfortunately have all encountered this at some point in time in surgery, where we have a lot of pus that comes out of the wound, likely an infected joint. And the problem with periprosthetic joint infection or surgical site infection, the status of it is, as we do more cases, and there's going to be more infection. The percentage can remain the same, but the problem, the number will increase because we're just doing simply more total joint arthroplasties. So because of that, we have to prevent them. There's ways that are preventable, and what I like to focus on here are called modifiable risk factors, meaning things that we can change as physicians and patients, as opposed to non-modifiable risk factors. And I'm going to go through these one by one. The first one that we do in the United States a lot of times is MRSA and MSSA swabbing. The idea is that prior to surgery, 2 to 6 weeks, you get a swab of the nares and you test for MRSA and MSSA. If it's positive, we treat with intranasal mupirocin 5 days, twice a day, and chlorhexidine body wash 5 days prior to surgery washing. Actually, everyone gets a chlorhexidine body wash, regardless of our MRSA or MSSA status. What it's really useful for is if the patient is MRSA positive, then we give them vancomycin in addition to cefazolin. We give cefazolin if they're MRSA negative and MSSA positive. So that really dictates the type of antibiotics we give. Does it work? This is a study done in New England Journal of Medicine, which was a prospective randomized controlled trial and found a 56% reduction in Staph aureus infection. Now, this is not just in orthopedic patients. This is in a large group of surgical patients. But they found that if you reduce the colonization in the nose, then you reduce the infection at the site of surgery. So it really has 56% reduction is quite large. We did this as a study looking at a collection of all the orthopedic surgery. Now, this is not just total joint arthroplasty. This is all orthopedic surgery, and found that there was a significant amount of surgical site infection reduction when implementing decolonization of MRSA and MSSA. Looking just at total joint arthroplasty patients, on the day of surgery, if you use MRSA, looking at MRSA, if you did treat them, there was 0 MRSA on the day of surgery. On the day of surgery, MSSA was still positive in 10 patients. Some patients became positive, some patients didn't do the treatment, and some patients remained persistently positive despite treatment. So there's only 100 patients in the study, but it does show that it is helpful to do decolonization in patients. The benefit is that it directly reduces Staph aureus colonization, and it reduces the likelihood of subsequent surgical site infections and periprosthetic joint infections. The downside is that it costs extra and that someone has to monitor the results of the laboratory tests. And it can lead to antibiotic resistance when using mupirocin. So people have indicated that they should use some other product. That's like a sticky product here that's indicated. And we use this sticky product, it's a betadine product, compared it to saline and compared it to regular povidone iodine, and found that all 3 groups reduced the colonization of MRSA and MSSA on the day of surgery. You can see at 4 hours, this is the results here. The sticky product, that's betadine, was the best reduction, followed by povidone iodine, followed by saline. At 24 hours, they did both all increase again, but it was still a little bit lower for the sticky betadine product. So it could be useful to do this as a topical solution right before the operating room. So right before the operating room, we actually use a betadine swab in our patients prior to surgery. Malnutrition is another area that we have to watch out for. The problem is malnourished people may not look malnourished. The person on the right here looks malnourished, but that's not always the way patients look. The one that we almost always use is albumin 3.5. So I get that on every single patient, and if they're malnourished, I want to increase their protein level. You can also look at total protein. Plastic surgeons like to look at pre-albumin, total lymphocyte count, iron, transferrin. So those 3, the total lymphocyte count, iron, transferrin, have to do more with iron. And then vitamin D is an area that we've gotten more interested in. In the Journal of Arthroplasty, they looked at malnourished patients based on the definition of albumin and found that there was increased hematoma formation, infection, and renal and cardiac complications. What was interesting that is patients with a body mass index over 30 was present in over 40% of malnourished patients. So again, just because a patient doesn't look malnourished doesn't mean that they aren't malnourished, and they had a higher complication rate. What we want to be careful of is looking at micronutrients. What we've looked at is macronutrients, albumin, protein, things like that. In the future, we're going to want to look at things like B12, B6, folic acid, vitamin A and E, zinc, chromium, selenium. These are the micronutrients that can dictate potentially our patient's recovery. How do I address my patients if they have low protein levels? I have them take these supplements. So these are protein supplements. They take them twice a day, 14 days prior to surgery. I try to use the glucose version of it because I want to reduce their amount of sugar that they're taking. If they take too much sugar, that's problematic. Vitamin D is an area that we become really interested in. They've shown that in the wrist, they've shown that in revision total joint arthroplasty, that if a patient has low vitamin D, they have higher complication risks. So now we test everyone for vitamin D prior to surgery, and the vitamin D level is between 10 and 30. This is how we supplement them. If they're less than 10, we actually send them to an endocrine consult and then do a high dose vitamin D. We're actually doing a prospective randomized trial looking at this. 2 months prior to surgery, we're testing them for vitamin D levels and looking at low versus high dose vitamin D in terms of supplementation. And that's what we're randomizing them to. So 1 month prior to surgery, we're randomizing them to low versus high dose vitamin D. And we're looking at 3-month complications. Now they're taking vitamin D for the 3 months. And we're looking at reoperation, readmission, and as this topic is talking about, surgical site infection or periprosthetic joint infection. Diabetes is something that affects, unfortunately, both Americans and Chinese. The problem with diabetes is that it's not just diabetic patients. It has to do with how we regulate sugar. Surgical stress antagonizes insulin, meaning when a patient undergoes surgery, it antagonizes insulin, and it can predispose patients to increase glucose levels. If you have increased glucose levels, it impairs the abilities of leukocytes to stop infection, essentially. So that's problematic because after surgery, bacteria always enters the wound. The problem if you have high glucose levels, that reduces the ability of your white blood cells to combat that. So hyperglycemia predisposes both diabetic and non-diabetic patients to infection. What do we do prior to surgery? Again, I'm looking at modifiable risk factors. I use a cutoff of hemoglobin A1C 7.7, and this was developed by a group of individuals from AAHKS, and I found that's the major point where PJI increases exponentially both at 90-day and 1 year. I actually like to try to maintain glucose levels under 200. If they're over 400 on the day of surgery, anesthesia will not proceed with surgery in our country. Now, this is a test here of hemoglobin A1C, which is glycosylated hemoglobin. Hemoglobin has a half-life of approximately 3 months. Fructosamine is another marker that we can use, and this is glycosylated albumin, which has a half-life of 2 to 3 weeks. So it's a better short-term marker of someone's glucose levels. At a cutoff of 292, you can see there's increased risk of reoperation, readmission, and overall complications. So it's another area we can look at and hopefully modify patients prior to surgery. We looked at patients who had high glucose levels on the day after surgery. And we found that if a patient's blood glucose level was over 137 on the day after surgery, the risk of infection increased. 137 is not a very high glucose level. So that was really kind of concerning that should we be better monitoring our patients in the postoperative period and reducing their ability to be hyperglycemic in that period. So we wanted to see when patients were most hyperglycemic. This is a study we did here where we measured blood glucose levels before surgery, right after surgery, at 5 p.m. on the night of surgery, at 9 p.m. on the night of surgery, and the next morning, and find out which was the highest point. And probably not surprising, the 9 p.m. on the day of surgery, and this is including people who ate, was the highest. So because of that, we go, how can we try to regulate patients' blood glucose levels? What we did is we placed everyone on a consistent carbohydrate diet, meaning everyone got less than 75 grams of carbohydrate per day. That's hard when you think of rice and bread and things that we like to eat after surgery. But the idea is if you keep it on a low, consistent carbohydrate diet, non-diabetic patients had better controlled glucose. Diabetic patients had pretty well-controlled glucose, and that's probably because they're diabetic and they're used to controlling their glucose levels. But in non-diabetic patients, those with the low carbohydrate diet actually had more regular glucose levels. Smoking is another area. Smoking is a big problem among our patients, and they increase the risk of short-term complications and reoperation for infection 90 days after surgery. The problem is nicotine causes microvascular constriction. And when you have constriction of the blood vessels, you have increased carboxyhemoglobin and decreased oxygenation to tissue. If you don't have oxygen to the tissue, you can't heal your wounds. So that's a big problem, of course. So for every one of my patients who smokes, I had them quit smoking. And then I test them 2 weeks later for serum cotinine and nicotine levels, both of them. You can test in the serum, blood, or saliva, and some people even use a breath test, but I use serum because it's the most predictable. The half-life is 20 hours, and it predicts smoking within the last week, meaning if a patient says, oh, I just quit, then I can detect that because it has to be traditionally within the last week. So if the levels are less than 10 nanograms per milliliter, then it's likely they have stopped smoking. When do I ask patients to stop? At least 4 to 6 weeks prior to surgery. So I see them, ask them to quit. Once they quit, they call us. I test them 2 weeks after quitting, and then I give them a surgical date. I will not give them a surgical date in advance of that. And it has shown decreased complications if they stop. Anemia is another area to be careful in our patients. Women, by the WHO criteria, have an anemia if it's under 12, and under the same criteria for men, it's under 13. If the hemoglobin hematocrit is less than 10 and 30, you can consider sending them to their doctor, primary care doctor, or hematologist for a workup of their type of anemia. Again, we're looking at modifiable risk factors. If they have low iron, low vitamin B12, or low folate, you can give them those supplements and make them better. But if they have chronic renal insufficiency or chronic inflammatory disease, it's likely you won't be able to change much of that. Iron, if you give it, do it 325 milligrams by mouth 3 times a day and start 3 to 5 weeks prior to surgery. The key factor here is that you want to give them something to prevent them from being constipated, because iron can be really constipating. Another option is intravenous iron. It acts faster and it's useful in hip fractures. And it's also good if a patient cannot tolerate oral iron. You can use this for anemic patients. This is called Epogen. It acts like human erythropoietin. It stimulates bone marrow and it increases red blood cell production. Lance Armstrong made this very popular only because he used this as a performance-enhancing drug. Used in patients, this is a recommended dosing. That said, the problem with Epogen is that it's expensive and it's really difficult to get approval for administration, at least in our country. And most importantly, it's increased mortality, which is a big problem. You can have increased cardiovascular events, thromboembolic events, stroke, and tumor progression, which is always problematic. The last area I want to talk about is patients who have rheumatoid arthritis or SLE. It's a systemic lupus erythematosus, and patients who are on these medications that are called DMARDs, or disease-modifying anti-rheumatic drugs. We paired with AHKS and ACR, which is American College of Rheumatology, to come up with some guidelines on these patients. What we found is that these type of medications, you want to continue through surgery. And this changed my practice because patients who don't get these medications have an incredible amount of pain after surgery. So if they're on methotrexate, sulfasalazine, hydrochloroquine, leflunomide, doxycycline, or Xelta, you want to continue taking these throughout medications. These are some other medications that are specific to SLE that are also really good to continue. Cyclosporin, tacrolimus. Even for our transplant patients, they are on these medications. So we now continue them during surgery. These are the ones you want to withhold prior to surgery. Most of these are biologics, like Remicade, Humira, Etanercept. And you want to see the timing since the last medication on the very last column on the right. Sometimes it's only 2 or 3 weeks from the last dosing. Sometimes it's up to 13 weeks after surgery. So you want to be careful of when you restart these medications. And this is true for other ones that you want to see after last doses, depending on what type of disease that a patient has. Again, restart the basic biologic therapy once the wound shows evidence of healing. That's average of 14 days. And glucocorticoids, you want to continue the current dose of glucocorticoids rather than administer a super therapeutic dose, meaning if a patient's on 15 milligrams of less of daily steroids for any reason, just continue that dose. Don't increase it. So the problem is if you increase the steroids, you increase glucose. And if you increase glucose, you increase your risk of infection. So you have to be careful how they all tie along together. So in summary, surgical site infections are still a big problem for total joint arthroplasty. You want to optimize patients prior to surgery with modifiable risk factors and work with other specialists such as nutritionists, endocrinologists to improve your patient conditions. Thank you very much.
Thank you, Dr. Chen, for sharing us her experience of prevention of surgical site infection. Now I will introduce the diagnosis and management of SSI. I'm Liu Xianzhe from Union Hospital. As we all know, orthopedic patients have the highest risk of SSI of all surgical patients, especially for the patients after internal fixation of fracture. The SSI rates may be as high as 3.6%. After foot and ankle surgery, the rates is between 1.2% and 2.3%. And after spine surgery, it's up to 4.4%. the surgical site infection are common, and the number of SSI is probably underestimated because half of the patients were discharged from hospital. And the PJI may appear even later. Just now we mentioned. And the patient with SSI stay in the hospital for longer time and increased healthcare costs. So surgical site infection after TJA is an annoying complication, and without appropriate treatment, will transfer from superficial to the deep, even periprosthetic infection. And before we diagnose the SSI, we need to be aware of the definition of SSI. What is SSI? The surgical site infection is an infection that occurs after surgery in the part of the body where the surgery takes place. And the CDC definition states that only infections occur within 30 days of surgery or within a year in the case of implants should be classified as surgical site infection. And the term surgical site infection was introduced in 1992 and to replace the previous term surgical wound infection. And SSI remain a major cause of morbidity and mortality, despite improvements in infection control technique and surgical practice, and impose substantial demands on healthcare resources. So this figure shows the category of surgical site infection. We can see from the figure, the SSI were divided into superficial incisional SSI, deep incisional SSI, and organ space SSI. The superficial incisional SSI was affect the skin and subcutaneous tissue, and deep incisional SSI is related to the deep soft tissue, including the fascia and muscle. And the organ or space SSI is related to organ and space. In our orthopedic operation, it means it related to the prosthesis and bone. And after introducing the category of SSI, we move on the wound assessment. This is a manuscript published on Lancet in 1986. In 1986, Dr. Wilson published the manuscript named A Scoring Method for Post-Operative Wound Infection for use in clinical trials of antibiotic prophylaxis. He also concluded a method of assessing wound healing, which has been devised that defines carefully the characteristic to be considered, and the points are given for the needs for additional treatment for presence of serious discharge, erythema, purulent exudate, and separation of the deep tissues, the isolation of bacteria, and the duration of inpatient stay. Depending on the wound score, wound infection can be divided into satisfactory healing, disturbance of healing, minor wound infection, moderate wound infection, and severe wound infection. The scoring system is still useful nowadays. And the serous exudate means a clear, thin, and watery plasma. It may be normal during the inflammatory stage of wound healing, and a small amount of the serous exudate are considered as normal. And erythema, when the bacteria are present in the surgical wound, nearby blood vessel will be enlarged to help combat the infection and making the skin look reddish. And any reddish more than 2 inches away from the incision edge is a cause of concern. And the purulent exudate is an inflammatory exudate with a high concentration of leukocyte, predominantly neutrophils and dead cell, and inflammatory molecules, for example, the cytokine, lysozyme, and the degree of enzyme proteolysis determines the thickness of the fluid. And the separation of deep tissue, the surgical wound dehiscence is the separation of the margin of closed surgical incision that has been made in skin with or without exposure or protrusion of underlying tissue, organs, and implants. And the most widely recognized definition is from the CDC criteria, where surgical wound infection are classified into superficial, deep, and organ space infections. And if we want to make the diagnosis of superficial incisional SSI, we must meet the following criteria. First is the day of event occur within 30 days after operation, and it involves owning skin and subcutaneous tissue of the incision. And the patient has either purulent drainage from the superficial incision or the organism identified from an aseptically obtained specimen from the superficial incision or subcutaneous tissue, or the superficial incision that is deliberately opened by the other surgeon or physician. And the diagnosis of superficial incision SSI should be made by the physician. And if we want to make diagnosis of deep incision SSI, we also must meet the following criteria. First is the date of the event occur within 30 days or 90 days after orthopedic surgery operation. And it involves deep soft tissue of the incision. For example, it can relate to the fascia or muscle layers. And the patient has purulent drainage from the deep incision or a deep incision that spontaneously dehisced or is deliberately opened or aspirated by the other surgeon. And also the organism is identified from the deep soft tissue of the incision by a culture or non-culture based microbiological testing method, which is performed for purpose of clinical diagnosis or treatment. And if there is an abscess or other evidence of infection involved in deep incision is detected, or gross anatomical or histopathology exam was positive, we ask doubt the patient I've already had the deep incision SSI. And for diagnosis criteria for organ or space SSI, it must meet the following criteria. The date of the event occur within 30 or 90 days after operation and involve any part of the body deeper than the fascia or muscle layer that is opened or manipulated during the operative procedure. And also the patient has at least one of the following: purulent drainage, organism identified, or abscess or other evidence of infection involve the organ or space. And now we move to the management of surgical site infection. There is many methods help us to make the diagnosis of SSI and help us to management the SSI. First is the culture. Its strong evidence support the synovial fluid or tissue culture and a strong rule-in test for the diagnosis of infection. Negative synovial fluid and tissue culture do not reliable exclude infection because multiple tissue culture should be collected to improve the accuracy of infection diagnosis. And a single positive culture from an organism is of limited virulence was shown to have poor predictive value as a rule-in test. And two distinct positive cultures for the same organism provided strong evidence of PJI. And the duration of culture incubation should be incubated for more than 14 days. And the yield of culture was reduced when the antibiotic therapy was administered within 14 days. That means before we carry out the tissue or synovial fluid culture, we should ask the patient to stop the administration of antibiotics at least 7 to 14 days. And for C-reactive protein, it's strong evidence support the C-reactive protein is a strong rule-in and rule out marker for patients with suspected surgical site infection. The elevated CRP level can be misleading in case of chronic inflammatory conditions, neoplasm, and metabolic syndrome that can cause its elevation, and therefore should be monitored over the entire course of treatment. We should be also aware of that. And the CRP was found to be both sensitive and specific in detecting SSI, even PJI, and served as an accurate screening tool with a positive or negative value, demonstrating the likelihood of the infection. And for the ESR, it's limited strength evidence and does not support the use of ESR alone to rule in or rule out this SSI. Because there are many high quality studies have demonstrated the ESR is a solitary test to diagnose or exclude surgical site infection is moderate or weak, and is felt to be variable with response to time from surgery and in presence of other confounding factors such as inflammatory arthroplasty to be considered as an accurate tool in diagnosis alone, but may be considered as a tool to be used in conjunction with the other test, especially with CRP test. And those two risk factors for SSI, just now Dr. Chen has already explained. I will move on to the other sections. Once during I preparing the slides, I found the website of ALS also guidelines, and we can find the solution for SSI according to different indication profile of patients. After finish choosing the location, hardware presence, implant removable, classification of infection, organism susceptibility, host factors, and then we can have the procedure recommendations under certain circumstances. And I make a summarize the AOS recommended treatment for SSI, and the AOS recommendation for treatment for SSI includes antimicrobial systemic treatment, the local superficial non-surgical wound care, the surgical debridement with or without implant retention, or partial exchange or partial removal, and single stage or multi-stage revision. I will focus on antimicrobial systemic treatment and surgical debridement. Before discussing the antimicrobial treatment of SSI, we should be aware of, in most SSI, the responsible pathogen originate from the patient's endogenous flora. The most commonly isolated organism are Staphylococcus aureus, coagulase negative Staphylococcus, and the Enterococcus and the E. coli. However, the pathogens isolated depend on procedure. And in addition to the patient's endogenous flora, SSI pathogens may originate from exogenous sources, such as members of the surgical team, the operation theater environment, and the instruments and materials brought within the sterile field during the procedure, during the operation. And such pathogen are predominantly aerobious, particularly the gram-positive organism, such as Staphylococcus and Streptococcus. And an increasing number of SSI are attributable to antibiotic resistance pathogens, such as MRSA. And this development may reflect the increasing number of severely ill or immunocompromised surgical patients, and the widespread use of broad-spectrum antibiotics. The pathogen may also originate from preoperative infections at a site remote from the operative site, particularly in patients undergoing insertions of a prosthesis or other implants. And the recent study assessing the current practice of prophylaxis throughout the world has shown that overconsumption of antibiotic drugs, inadequate use of antibiotics, and inappropriate timing of administration still remain a remarkable issue in surgical prophylaxis, and leading to an increased risk of adverse effect, hospital cost, and emerging resistance microorganism. And the choice of the antimicrobian should aim to provide first the activity against the common bacteria that might contaminate the surgical site, and second, adequate serum and tissue concentration, and third, the drug should be safety, and fourth, the administration for the shortest effective time in order to reduce the side effects and the development of drug resistance and also the cost. And nevertheless, the choice of an appropriate antimicrobian agent should be based primarily on efficacy and safety, and the broad spectrum antibiotics should be avoided due to the risk of promoting the drug resistance. And this table shows several antimicrobian drugs. According to the table, we can figure out the antibiotics have different concentration in different tissue. Just as naloxone, as an example, in the synovial fluid, the diatomizing, the concentration is the highest. And in the osseous tissue, the naloxone has higher concentration than vancomycin. And after we finish discussing the antimicrobian treatment, we move on the next very important topic, the surgical debridement. And if an infection manifests early in the post-operative period, the debridement in combination with antibiotic therapy and the retention of the prosthesis is a potential successful treatment option. And the success rate described in research varies greatly from 2.8% to 100%, but more recently is estimated suggests that it's close to 80%. And the criteria proposed for the use of surgical debridement is a duration of symptoms is less than 1 month, and infection with Staphylococcus or Streptococcus, and no loosening of the prosthesis, and no evidence of poor soft tissue integrity as a result of prior surgical procedures. And the debridement should be performed as early as possible after the onset of the symptom of infection to avoid treatment failure, ideally within 1 week, as this treatment avoids major revision surgery to replace the joint is particularly advantageous for the elder patients. But if you fail to perform the surgical debridement, and the revision surgery will be required. And SSI following the orthopedic surgery is distressing and painful, not only for the patient, but also for the surgeons, and affecting the patient's quality of life and its costly for healthcare provider. It can lead to delay in recovery of patients, and it can cause osteomyelitis and removal and reimplant of the joint prosthesis. Even for some severe patients, they will have the amputation, sepsis, even death. So since I think it's inevitable that as a joint surgeon, every one of us maybe will have the cases with SSI, even PJI. So the precise diagnosis of SSI, depending on the type of procedure performed, was very important. And however, early detection is of great importance for successful management across all interventions. So stop superficial or deep SSI transform into PJI. And the last slide I attached is the website for AOS and also guidelines. You can have the suggestion for the treatment of different stage of SSI according to the website. And that's all for my presentation. Thank you.
Good job. That was a lot of information. That was very helpful and useful.
Thank you. And let's move to the second section. We can do the case discussion. Okay.
Great.
Okay, let's move on to the case discussion of this seminar. And I will make the introduction of this case. It's a male patient. Is 37 years old in 2021. And the chief complaint of this patient is incision of right hip was reddish and swollen with exudation for 1 week. And past medical history, he had a internal fixation for fracture of right femoral neck in 2007. And he had total hip arthroplasty in 2020, 1 year before this time. And he also had epileptic disease and controlled by drug. And also the blood uric acid is high and is uncontrolled. So this is the X-ray for this patient in 2020. The left figure is pre-operation and the right figure is post-operation after the total hip arthroplasty. So now is the first question. Will the malposition of the hip prosthesis raise the mobility of incision problems for these patients?
So if you go back to the last X-ray, it looks pretty good. I know that you guys are very tough on yourselves. We are also very tough on ourselves as surgeon, but the position of the component looks pretty reasonable. You want to make sure that you keep the offset. This is a young patient. So if you go too medial, that's going to be problematic. So I think the position actually is problematic. It is not problematic. I think that's actually good. I think the bigger concern might be is which approach can lead to potentially more wound problems after surgery when it reduces infection. But the implants look good. So I say they look great.
Sure. As I know, the surgeon who carry out the total hip arthroplasty used the same incision in 2007 for the first surgeon who did the internal fixation for femoral neck fracture. And now in 2021, before the hospitalization, we find the incision of the right hip of these patients. And the blood test in the outpatient clinic, the white blood cell count is higher, the CRP, ESR, and the UA is not normal. And now is the second question. What are the possible reasons for the patient developing SSI?
That's a tough one, right? So it's one of those things where when it comes to SSI, it is multifactorial. There's multiple different areas that can contribute to it. So he had previous surgery there. That's always a big red flag. Just because you already cut in through tissue, you're coming back again. So that can make a difference. He's on anti-epileptic medications. Those can also be problematic for patients as well, too, in that they can reduce their threshold for epilepsy is one. And then two, potentially some of those medications can reduce immunity. And so by doing so, that can be problematic as well, too. He also has uncontrolled, I think he's had hyperuricemia. So that's also could be possibly problematic in contributing to this whole overall picture. There are other factors that we had talked about before. Malnutrition, he could be malnourished. We don't know about other areas too that we don't look at. So these can all contribute to infection, unfortunately.
Yes, I totally agree. And the third question, how can we identify whether it's just SSI or it's PJI?
So personally in my practice, and I'd love to hear about your practice as well too, every time we see a patient, probably when we have an ESR and CRP to start off with. Now it's a pretty good rule out test if they're both negative, but not necessarily. So I always try to get an aspirate of the patient. Now in this case, when you say SSI versus PJI, it can be both, right? Because it can fit both the criteria. Because the previous picture, shows that it's right at the skin, it's right at the head there, right? It's likely considered a sinus tract. If you make a little incision there, all the fluid will likely come out. So if it's a sinus tract, by definition, it's a PJI. That's the benefit there. Surgical site infection most likely is going to go deep. So a lot of time PJI and deep organ space from the CDC definition go together. So it can be both, I would say. But PJI is more of a deeper one, and that's definitely a bigger issue there.
Yes, for this patient, before the operation, we did the aspiration too, and also we used under the ultrasound to get the biopsy, and also we get the fluid around the wound and give the bacterial culture, and the result is negative. We also send the sample to have the NGS, and it's also negative. Yeah, so the surgeons did the debridement and suturing, and we cut the incision from outside in and from the skin to the subcutaneous tissue to facial latex to gluteus muscles, and we found the infection may be constricted to superficial or subcutaneous tissue. Yeah, and this is the results for NGS. I'm sorry, it's Chinese, but its results show there is MSSA of the sample we collected from the superficial or subcutaneous tissue. Yeah. And now is the microbiological examination for MSSA, and we found there are many sensitive antibiotics. And now is the fourth question: how can we choose the appropriate antibiotics, and maybe how long time for the treatment of these patients?
As your very good presentation highlighted, we don't know the answer, unfortunately. I wish we did know exactly what the right duration and for each organism and each patient what the right number is. At least this microbiological examination helps us tell us what it's sensitive to. A lot of times what we do is we pair with our infectious disease specialist, and you want to know what works in your hospital, right? My hospital might have a higher rate of MRSA than your hospital, so vancomycin is very important to add to the treatment regimen. In other hospitals, it might be other medications that are more useful. So most of the time in our patient population, for example, if the staph aureus is sensitive, but for example, you're afraid that because they're immunocompromised or have other areas that they have a higher rate of MRSA, then we probably use something like vancomycin because it's sensitive to it. Sometimes people will use combination therapy, right? Linezolid, the benefit, it's got gram-positive and gram-negative to it, right? So you can actually get both combinations. The other downside, though, is linezolid is more expensive in our country. So you have to kind of balance all of them. For duration-wise, we normally do what's traditional. We normally do 6 weeks of intravenous antibiotics, followed by potentially oral suppressive antibiotics after surgery. And that's something to think about when choosing a medication to see if there's an oral version of it. The one thing I'd like to highlight is there was a really good study out of Oxford, and they randomized patients to oral antibiotics and intravenous antibiotics, and they found that there was no difference. So you could consider oral antibiotics in your patients instead of intravenous. We still do intravenous antibiotics in most of our patients, but it is an option. And 6 weeks is what we average do it for.
Yes, thank you. And this is the timeline for us for the antibiotic usage. First, because considering the patients have high uric acid, so the function of kidney is not intact. So we do not choose vancomycin when we choose the other kind of antibiotics. And after 2 to 4 weeks, the IV antibiotic treatment, we transfer to oral administration. And after 6 weeks, and the wound healed very good, and the CRP test and ESR and white blood cell count become normal. But you can see the uric acid, the level is still high. So we ask him to consult the physician to make the changes of this kind of drug to decrease the uric acid of these patients. Yes, that's all for case discussion. And I think it's time to make a summary for this episode since the time is limited. Thank you, Dr. Antonia Chen. Would you please offer us some take-home message for the prevention and treatment for the SSI, please?
I said the key factor is prevent infections before they happen. Then you don't have to worry about diagnosis or treatment. So whatever you can do to optimize your patients prior to surgery, for example, control hyperuricemia if possible, things like that. Whatever you can control diabetes, control smoking or stop smoking. Things that we can control to optimize our patients to prevent infection, because we've all treated infection and it's devastating to treat infection. Secondly, is if you want to diagnose it with criteria that's available to you. And you did a very nice summary of what the different diagnostic criteria are. And finally, treat it in the right manner. The hard part is we don't know exactly what the right manner is, right? If we can get away with a debridement, antibiotic, and implant retention, that's great. But if we can't do that every time, then you have to go to more invasive 1 or 2 stage exchange arthroplasty. So prevent it so we don't have to treat it.
Thank you, Dr. Chen, for your take-home message. At last, I would like to thank Arthroplasty Society in Asia for providing us the opportunity to participate in this online seminar. And at last, we are organizing a special issue on SSI in the Journal of Arthroplasty, which was meant to consolidate our understanding on prevention, diagnosis, and treatment of SSI, from basic etiological research to clinical translational therapy, which was established as an open platform for exchanging ideas of addressing advances of prevention, diagnosis, and treatment of surgical site infection. We do encourage researchers to contribute their original research articles and works related to our special issue. The special issue will be published in the Journal of Arthroplasty. And finally,
I'd also like to thank the Arthroplasty Society in Asia for providing this opportunity. It's been fantastic to be able to speak to one another, share some ideas, and share ideas with everyone else. The 8th annual meeting of Asia is just around the corner, which will be held virtually on August 27th to 28th. I'm honored to share my experiences on the PJI session, and I hope you guys can all tune in to learn more about it. To find out more, scan the code showing on a screen to register.
Okay, everyone. This is the end of the 3rd episode of Asia Novel Seminar, Season 3. Thank you all for participating and watching. See you next time. Thank you, Dr. Chen.
Thank you so much. It was fantastic speaking with you.